Welcome everyone, and thank you for attending this Lunch and Learn session organised in collaboration between the Knowledge and Library Services at NCIC and Boost, the North East and North Cumbria Learning and Improvement Community. So my name is Ashley Eaton and I am from Boost, and today we are joined by Professor Ahmet Fuat, who is a GPSI for Cardiology in Darlington, and he's going to be speaking to us about improving outcomes in patients with heart failure across Tees Valley, a quality improvement project. So these Lunch and Learns are designed to be a relaxed and informal space for health and social care staff to come together and share experiences. Before we kick off, we're just going to do some very quick protocols. So if you can keep your webcams off during the session, that would be much appreciated. Please mute when not speaking. Post any questions in the chat, and we'll also have some time for questions at the end. Listen with respect and be present. Please pass on, share the learning, spread the word about these sessions, and please be aware that we are recording. We will post a link to be able to give feedback in the chat, so if you could complete that, that would be much appreciated. It's very short, just a few questions. I will now pass over to Ahmet.
Thank you very much, Ashley. Thank you for inviting me. So I thought, I was asked to talk about the Tees Valley project, but I thought I'd put it into context. First of all, my main declaration here is that since retiring last year, and after this project started, I became medical director of Oberoi Consulting. I still wear lots of other hats. But I just want to start with, why is heart failure so important? Well, we know that up to 1 in 5 of us will get heart failure in our lifetime. There are now over 1 million people in the UK living with it, and it's the biggest cause of hospitalizations in over 65-year-olds, and 30% of those are readmitted within 90 days. It also not only costs the patient, the carers in terms of quality of life, but it affects the NHS budget, and heart failure itself uses up 2% of the total NHS budget. And HFpEF in particular, which I'll mention, is something that we don't do very well, and patients get hospitalized. And up to 30% of those die within a year of hospitalization. We know that the overall prevalence of heart failure is increasing due to an aging population and improved survival post-ischemic attack disease. In other words, we're keeping people alive longer with our revas procedures and the medications we have. So what is heart failure? Well, it's a clinical syndrome due to structural or functional cardiac disorder that affects the ability of the heart to pump, to function as a pump. And we classify it using the left ventricular ejection fraction, which is normally between 50 to 70%. The heart can never pump 100% of the blood in the left ventricle out. And we classified according to that. So less than 40%, it's reduced ejection fraction, 41 to 49% mildly reduced, and over 50% preserved. Why is that important? Well, it's important to, one, understand the pathophysiology, but also because treatments are different for different types of heart failure. So it's easy to understand reduced ejection fraction. You have a stretched, dilated, baggy heart that fails to eject blood. With preserved ejection fraction, it's often older people who are diabetic, hypertensive, may have left ventricular hypertrophy, where the cardiac muscle stiffens. You can see that the left ventricular capacity shrinks, so that even if the heart is pumping out 50% or more of the volume, it's often less than what is pumped out by a heart with reduced ejection fraction. So it just helps us understand it a bit. And NICE guidelines are due to be done soon, re-evaluated. I don't think the diagnostic pathway will change. We're being asked to use NT-proBNP to identify patients to refer. So over 2,000 refer within 2 weeks, 400 to 2,000 refer within 6 weeks, and under 400 NT-proBNP, heart failure is very unlikely, so we should think of another cause. We obviously need to examine the patient, consider other investigations, but then refer a patient for echocardiography. So this is the simple investigation pathway. Clinical suspicion, breathlessness, peripheral edema, exhaustion, fatigue, especially if they already have cardiovascular disease, atrial fibrillation, COPD, things that contribute, do natriuretic peptides, then refer for specialist opinion. Now, the work on Teesside was based on the work that I did along with my colleagues in Darlington PCN over many years. So I opened the country's first one-stop diagnostic clinic for suspected heart failure using natriuretic peptides with my colleague, Professor Jerry Murphy, and then our nurses, Vicky Duffy and Jill Drinkall, in January 2002, the first in Europe, let alone the UK. But after that, in my own practice and then in Darlington practices, we started targeted detection. So patients who are more likely to have heart failure, patients who have hypertension, existing coronary heart disease, they've had a stroke, they've got diabetes, they've got AF, they've got CKD. We see over 90% of these patients in our long-term conditions clinics in primary care. So we started in my practice, one of my nurses, Pauline Emerson, has since retired, that all these patients that you see here, we ask specifically about symptoms of heart failure. Do they have nocturnal dyspnea, orthopnea, so breathlessness when lying flat, waking up in the middle of the night gasping for breath, dyspnea on exertion, edema, breathlessness? If they did, we then did NT-proBNP, and we found that over that time, in my own practice, and then as we spread it across Darlington CCG as it was, we had the highest prevalence of heart failure in the region, but actually the lowest rate of admission to hospital because of highest optimization levels for medication and significantly lower than England as a whole, but we also had one of the lowest mortality rates for heart failure. And this you can see here, Darlington CCG right at the bottom. This led to the British Heart Foundation using the Darlington integrated heart failure model as in their blueprint for heart failure document. So we also need to think about heart failure. When I graduated in '82, we had nothing but diuretics or digoxin, but lots of new drugs have been developed, shown to be effective in heart failure, as well as devices such as cardiac rate synchronization therapy, implantable cardiac defibrillators, and ventricular assist devices or cardiac pumps. So, as I've said, NICE is out of date. It's due to be revised, but what we should be aiming for is the European Society of Cardiology guidelines. So anyone with reduced ejection fraction should be on an ACE inhibitor or an ARNI, which is sacubitril, valsartan, or Entresto, a licensed beta blocker, bisoprolol, carvedilol, or nebivolol, a mineralocorticoid antagonist, spironolactone or eplerenone, a SGLT2 inhibitor. The two licensed are dapagliflozin and empagliflozin, and a loop diuretic only if they need it for fluid retention. Under that green box, you can see the guidance for use of devices, which is beyond the scope today. But what we're aiming for now is the 4 pillars of evidence-based care in HFrEF. This is going beyond QOF, because in QOF, we're only actually being asked to start ACE, ARB, or ARNI, and a licensed beta blocker. We know that these 4 drugs work in different ways. Mechanistically, they have additive incremental benefits, and SGLT2s have recently hit the market. And if you look at this very powerful chart from Trump and colleagues in the US, you'll see that right at the bottom, you have placebo, monotherapies, and as you go up to the 4 pillars of care at the top, which I've described, all-cause mortality reduces. And this is how heart failure therapy has developed over the years. And this modeling paper by Muthi Vadagunathan and colleagues showed that if we use those 4 pillars compared to the 2 that are in QOF, we actually add years to the lives of patients, 8 years or more if they're 55, but up to 3 years when they're 80. And the average age of a new diagnosis is 76. In mildly reduced ejection fraction, the European Society guidelines are also saying use the 4 pillars of care if patients are symptomatic. And more recently, very recently, we've seen that even in heart failure with preserved ejection fraction, American guidelines are saying use SGLT2 inhibitors for all patients. So dapagliflozin or empagliflozin, and you can use the other drugs in specific subgroups, which you see there. What is also important is that we must keep patients on the highest dose of a RASI drug, so those are ACE, ARBs, ARNI, mineralocorticoid antagonists, and because from this trial it was showed that the orange is discontinued, the lighter blue is submaximal dose, and the dark blue is maximal dose. And you'll see that if drugs are discontinued or submaximally dosed, the death rates go up considerably and double in heart failure patients, in CKD patients, and in diabetic patients. So let's come to the Oberoi disease management platform, which we used on Tees side. So I'll come back to the Tees Valley project, but essentially NHS England put out a bid for novel ways of managing heart failure to optimize patient care. I was the clinician, wasn't employed by Oberoi at the time, but I helped Tees Valley CCG, then became ICP, to put in a bid in collaboration with Oberoi. And the Oberoi digital audit platforms sit within GP Systems, System 1, EMIS, and Vision. They run very detailed searches, which we can use to generate lists of patients, to validate the heart failure register, optimize medication, and then, because of our 12-month quarterly reporting and education, leave a legacy to continually optimize and manage patients. So we have searches and alerts. We also have interactive dashboards, which I'll show you later. Our interactive dashboards and reporting are coupled with quarterly feedback with goal setting at practice, PCN, and ICB level to empower healthcare providers to improve patient outcomes. And these are based on the latest clinical guidelines. And for this, we use the European Society guidelines and data analytics. So as I've already said, they sit within GP systems. There's alerts we can use too, as a patient turns up opportunistically, it may flash up to say patient on heart failure register, no subcategory code, patient on heart failure register with HFrEF, not on all 4 pillars, but also simpler alerts to say this patient needs X, Y, and Z, bloods, ECG, etc. So what we do is we deploy the resources, we generate a baseline report, which we then feed back to the practice in a training webinar. We debrief them, that we try and get a clinician and someone who knows the IT at least at that meeting, but ideally we like to give that training webinar to the whole of the practice staff if we can. And we also provide education on whether it be heart failure, AF, lipids, diabetes, atrial fibrillation at PCN level as well. We then give quarterly re-audits, which populates a dashboard so that the practice can track their performance. And at the end of the 12 months, we give a full re-audit report, feedback to the practice. They can then either decide to carry on using the searches we leave within their systems, or whether they want to purchase a further 12 months work by us. So reporting within the GP system, it generates lists like the one you can see on the left. Those within the live system, if you right click on it, it generates a list of patients. So if you look, say, at 2B, not on heart failure register with codes relating to heart failure 1, 316 patients, you would go into the notes and code them appropriately. And further on down, searches where someone may not have had an echo recorded or not on specific drugs. So we validated this initially in Darlington PCN and re-audited it. And you can see that even within a PCN where we'd done very well, we found that COVID had had an impact on coding. And we increased our prevalence across our big PCN of 115,000 patients, 11 practices, all on System 1, by 350 patients. Carmel is my own practice that I was at, as you can see. We have the highest prevalence, and even we found that we increased it slightly. But other practices saw significant increases. So we then did some work around coding. And after this session, there is a slide deck, very detailed on coding that we can share. I won't have time to go into it in detail today. We also can look at the patients with reduced ejection fraction, preserved ejection fraction. And if you look to the right, we increased that HFpEF by 134 patients, but there's a significant difference in coding between my own practice and all other 10 practices. So we did some work on increasing the confidence in diagnosing and coding HFpEF. We then rolled it out to PCNs across Tees Valley. And our early work, we covered 12 practices in Hartlepool Health and Eston PCNs. And the very early work, and we're still doing the work. We're just moving on to East Cleveland next, which will be our final one of the 7 PCNs we'll have worked in out of the 14. The 14 includes Darlington, so 8 out of 14 will have run this. we saw a significant increase in prevalence from just over 1 to 1.38%, an increase in HFrEF of 504 patients, HFpEF of 93, mildly reduced ejection fraction was very poorly coded, but we've tried to do that. And what this also does is it improves QoF income for practices. But perhaps more importantly, what we saw a reduction in patients on no therapy. So by 18, one therapy up by 22, two pillars 249, three pillars 72, and four pillars 125 patients. And if you translate that to the outcomes that I showed you earlier, where those on four pillars of therapy compared to those on two pillars of therapy are less likely to die, be admitted, have morbidities, then we believe this is a good surrogate for patient outcomes. We won't be able to show reduction in hospitalizations, etc., for a year or so while we collate the data. We then actually have gone on and rolled this out across 12 other PCNs out with Tees Valley from places like Leatherhead down south to Preston to Widnes. And again, we've shown a significant increase in prevalence. And across these 12 PCNs, almost 2,000 patients appropriately subcategorized and coded. But again, more importantly, we saw a significant reduction in no therapy, way up to over 470 patients on four pillars of care. So take-home messages, and I'll finish with a few minutes for questions if we have any. We need to validate our heart failure registers, ideally more than once, search for missing patients, use the umbrella code for heart failure plus a subcategory, and then remember, without HFrEF, HFmrEF, and heart failure being coded, can result in medication optimization being forgotten, which also affects QoF success. We then need to review all these patients. I would add HFpEF into there because we've started to do that work, but initially NHS England wanted us to concentrate on HFrEF and mildly reduced because at the start of the project, we didn't actually have licenses for SGLT2s for heart failure with preserved ejection fraction. And you can use Oberoi disease management digital audit platforms, but because it is a commercial company, there is a cost. There are ways practices and PCNs can get it through indirect grants, through industry, and I would always be happy to discuss that. We are about to actually start work across 11 practices in the North Cumbria GP Federation, stretching from Carlisle to Workington, to do exactly the same work we've done in Tees Valley. And lots of areas of the country are asking for this to be done because we have been shortlisted for national awards through HSJ awards, so Health Service Journal awards, and Primary Care Practice awards. So thank you very much. Some questions, questions if we have any. So thank you.
Thank you so much, Ahmet. It'll be really interesting to see the hospitalization data as well, because I mean, amazing outcomes already.
Yeah.
So.
Yeah, no, and these are surrogates. We know from trials that getting patients onto treatment definitely reduces hospitalizations, especially with SGLT2s, amazingly. So, it would be good to look at that, and we plan to do that, but we need to wait for the
Yeah,
health,
enough time.
the HES data to be able to get that.
Yeah. Any questions at all from anybody? I think Sheila might be typing in the chat. Feel free to come off mute, Sheila, if you'd like. And exciting coming to North Cumbria next, which is fabulous.
Yes. So we were contacted by Joanne Daly and Gert Gamelin, who's a GPSI in cardiology I trained, disappeared off to New Zealand but missed Northeast, so he's back. So we're hoping to start that work, and we always work closely with secondary care because we often identify patients who may not have been through the heart failure service, maybe because they've moved from another area, or sometimes a GP's made the diagnosis themselves, which we shouldn't really do as GPs. They should be assessed by a specialist team, unless there's a very good reason why they shouldn't be referred. So we will be working with the North Cumbria Heart Failure Services in collaboration. So yeah, it's really exciting to do that work as well. And this is why I joined Oberoi, because QI is such a big part of what I've always done in my career, because the only way to really improve patient outcomes, whether it be heart failure or COPD or asthma or diabetes, is to look for, to use QI to identify patients and go beyond QOF. And it's not always easy because GP practices are under so much pressure with the workforce, but group companies like Oberoi, and there are others, Interface, Inspira, etc., can help practices to supplement their workforce. But I do believe that to do it properly, which is why I joined Oberoi, is that we want to educate and leave a legacy, because we can't just keep going in. It should be carried on. So in Darlington, as an example, all 11 practices, I trained up CVD leads who varied from GPs to nurse practitioners to clinical pharmacists. And I also trained up a PCN CVD lead in all 14 Tees Valley ICP practices in heart failure, lipids, cardiovascular risk assessment, hypertension, AF, and palpitations. And many have gone on to do work and even overtaken Darlington in some areas. I can't believe it. Hartlepool doing better than Darlington in hypertension. Who would have believed it? But there you go. So yeah, no, and that's what we should be about. We should be about spreading good practice for the benefit of patients, but also the benefit of practices.
Perfect. And what a lovely note to end on there.
Perfect,
Ahmet.
Well, thank you very much for inviting me. And, I hope that you share the slides. I'm very happy for you to share them in PDF format and for people to watch the video. So thank you very much, Ashley.
Thank you, Ahmet. And thank you, everyone, for attending. Again, just a reminder, we have posted a link to be able to give feedback in the chat. We do have a number of lunch and learn sessions coming up, details of which we will put also in the chat. Our next lunch and learn session is on the 22nd of May at 1 o'clock, where we will be joined by Dr. Helen Howlett, who is a Senior Commissioner for Children, Young People and Maternity for the North East and North Cumbria Integrated Care Board. And she's going to be speaking to us about fetal alcohol spectrum disorder and raising awareness of that. So we hope to see you there. So once again, thank you so much, Ahmet. And I hope everyone enjoys the rest of their afternoon. Thank you.
Thank you very much. Bye, everyone.